and try to come up with an explanation or a hypothesis about what's going on. I have my paper here so I can take notes. I'm kind of giving you a bit more information than usual. I usually hide information. In this case, I'm giving everything that I had. And I probably would have taken away part of that information because I think one of the features, sometimes if you look at the information that, the signalment and the clinical signs, then you are going to be very biased about something because you're going to be, that can trigger like a hypothesis and then you're going to be very biased about that. I think that may happen in this case, but we'll see. So you can go either way. You can try to go through that in detail and say, my top differential is this. Do I find evidence of that? Or you can just look at the images and then just go from the images and then try to build a hypothesis based on that.
I'd be cheating if I say that I know border collies are prone to a particular type of congenital cardiac defect.
Okay, cool.
But I won't say. This is an Australian sheepdog, which is basically a crossbred sheepdog.
Mm-hmm. So I guess your silence is related to there's nothing like dramatically obvious that jumps and you can see, I suppose, unless you stop me. So
no,
but in what do you see?
I see lots.
Okay.
There's
oh, sorry.
Go, Jen.
There's I think a marked bronchial pattern.
Okay.
And I think subjectively the cardiac silhouette looks enlarged, but I haven't actually done a heart score or anything.
Okay.
I wonder, is there some left atrial enlargement there?
Okay.
Not, is it visible on the other? Not on the VD, I don't think.
Okay, good.
I know we can't see much of the abdomen, but the abdomen looks like there's maybe a loss of serosal detail.
Okay.
A lot, now that you've done that.
But it's a young dog.
Good. I'm taking notes of everything you are saying. So, and it's very interesting what you're saying. So, yeah.
There's some consolidation there at the at the carina. I wonder, is it edema rather than lymph node enlargement?
Okay, good. So the two considerations is, I suppose, lymph nodes. And the other, do you have another differential? What do you mean by consolidation? Do you have any disease?
It's radio dense.
Okay, so correct me if I'm wrong, but I think you're guessing along the lines of edema or pneumonia or like kind of an alveolar pattern.
I wouldn't call it alveolar.
Okay.
I think bronchointerstitials are better.
Okay.
Someone already called it bronchial.
Cool. Beautiful. Okay.
I feel like the vessels on the VD or the BV, I can't remember which one it is, look more prominent and larger than I would expect, especially in the right caudal lobe, particularly the veins, but they both look bigger than I would have expected,
Okay.
enlarged. Also on the left lateral, the right lateral, it looks like I'll just try and mark up what I'm seeing. in this area, maybe the aorta looks enlarged.
Okay.
I think there's something is causing, and there's a soft tissue density which is causing this little bit of, I guess, lower density lung to be visible, which we normally don't see. We don't see it on the other side. Yeah, not sure what that means.
Anything else? And probably before we go with any other finding, do you mind? I was planning not to bother you with it, but then I realized that you know how to draw on the images. So because you show me that you know how to draw on the images, do you mind showing us the enlargement of the pulmonary arteries and veins? What exactly do you mean? Beautiful. Okay, excellent. Very good. And then probably I should add that this is a DV projection, and it's based on the shape of that diaphragm. We can probably at the end try to clarify that, but for now, just believe me that it's a DV projection.
Yeah,
Okay.
yeah. I remember when you explained it earlier,
Yeah, cool.
a few months ago.
Yeah, cool. So the shape of the diaphragm, and then basically when you do that, there's a lot more of the lung superimposed over the liver, but the good news is that that lung is on top, so it's more aerated. So even though there is superimposition, like the grapes on top of grapes, you can get to see them, you can get to see the vessels very clearly because they are surrounded by air. And if you turn the dog around and if you have a VD, then based on the angle of the X-rays, it's going to be less of that lung superimposed over the liver, but then there's going to be a telectasis. So it's kind of, some people go more towards one or the other. I because of that explanation, I think I prefer the DVs, but that's another chapter. So perfect, very good. Pulmonary arteries and veins are enlarged. Okay, anything else that you want to add?
I'm also looking at just the soft tissue density on the right lateral cranial to the heart. I just don't see, I guess the mediastinal area looks like there's an increased soft tissue opacity there, like it looks thicker than normal, I think. And on the DV, just looking at an area where there appears to be an increased soft tissue opacity in the lung in a couple of areas where it's just slight, but it's more than other areas of the lung. That's the extent of what I've noticed.
So I'm gonna take a note about that. Like you want somehow like a patchy increase in lung opacity, something like that.
Yeah, and it looks more diffuse than specifically bronchial in those areas to me, like more like interstitial alveolar, but I can't see a bronchogram. So
okay, good. Yeah. Anything else? You sound all broken, like you were like hesitating. It's very funny feeling how you come out.
He's a robot. So funny.
I'm wondering, is there some right heart enlargement?
Okay, good. Yep. And based on, why are you showing us that line? Okay, so we're gonna leave the heart for a minute, Okay, and then we come back. I think it's a whole chapter about we need to talk in particular about the heart. Is there anything else, or we can go, we see if Helen can find a little bit of signal. Maybe if you go with your hands like this, Helen, then they can act like an antenna, and then you can get some signal. I'm kidding. Anyway, so I go through the findings, and then probably what I would suggest.
I'm
Okay, go.
walking. Is the right atrium? Is the right atrium?
Okay, good. So show us.
Enlarged?
Okay, so from all of that, I took that you think that the right atrium may be enlarged. And I don't know if it's you who is drawing those green lines. Right atrium. That was impossible for me to decipher. You got so funny, Helen. Okay, I guess you need to do something to get more signal. Okay, so we continue. What I would suggest doing is I go through the findings, and then before we try to go and clarify them, or let's see if we find disagreements. Make sense? So I go through them, and then let's see if someone says, I disagree with that. I disagree with that. Make sense? And then you can say, well, if you disagree, you say why, and then you try to give your version of things. Make sense? We may be all in agreement, but I think it's good to have this time to say, well, these are all the findings. Let's see if we are all in agreement, because there may be someone that wants to either add or modify something, or disagree and say, no, I disagree with that. So what I get is like the lung is abnormal. We went through bronchial pattern to bronchointerstitial pattern to possibility of some alveolar areas, areas of the lung with an alveolar change, an alveolar pattern. Then the heart, I think there are multiple calls about it being abnormal. And I think there's a comment about the left atrium being abnormal, probably the right atrium being abnormal. And then there is, I don't know if you want to put this together or not, but there seems to be something going on in that cranial mediastinum. I don't know if that is together with the heart or not. Then there is loss of serosal detail in the abdomen. Then there is enlargement of the pulmonary arteries and veins. And then there is something with the aorta, which looks like an enlarged aorta. And that's it. So are we all in agreement with that? Do you want to add or disagree, or how are we doing now?
I don't really see an aortic bulge on the DV.
Okay, so you are bringing an important point. So we can start discussing that point. So I think the person that mentioned like the enlargement of the aorta pointed to this area, and then there was this, and probably Helen is picking that border and saying, well, that may be the right atrium. So I think they are both right. And then, so I'm going to take the opportunity to clarify. So, and then to go a bit more in detail about the clock phase analogy, which is very, very important. So, and as we've been through this before, but we are going to review it again. So when you think about this area of the heart here, then basically that is kind of very non-specific, because there are three structures. It's different from this border. So if you pick this border, which is the cododorsal border, then we know that that's in dogs, that's the left atrium, and that's it. You know, you may confuse. So in some situations you can have a confusion, or you can be, but we are gonna. So with the lymph nodes, so if the trochanteric lymph nodes are enlarged, then something can look like abnormal in that area. But if we just restrict ourselves to the contour of the heart, then that's the left atrium. Now, when we come here, then it's not only the right, actually it should be the auricle actually. So it's not the right auricle and the atrium is here, but it could be the pulmonary outflow tract or it could be the aorta. So those three structures are in that area and they are all superimposed on the lateral projection. So if we come back to the other projection, then we have the right atrium here. Then the aorta is going to be, you can follow that line, and then it's going to be somewhere there. And then this is going to be the pulmonary outflow tract. Remember the borders at this level, the clock face analogy is telling us that there should be the aorta, the pulmonary outflow tract, and then the left auricle. So if we come back to this area, then be aware that you may find something abnormal there, but you immediately need to go and try to decide, if you can, which of those three structures that could be affected is the one that is really affected based on the other projection. Makes sense? Because this is very, let's say, non-specific. The three structures can result in an abnormal appearance. So like, for example, a tricuspid insufficiency can result in enlargement of the right atrium, and it's going to look like this in the lateral projection. Now, in the DV projection, it's going to look like there's an enlargement here, okay? And then similarly, like a huge aorta or an enlargement of the aorta, and then we discuss about which diseases can result in that. Then it can result in disappearance in the lateral projection, but instead of being enlarged here, it's going to be enlarged there. And similarly, if there is an enlargement of the pulmonary outflow tract, it can look similar in the lateral projection, but it's going to look like a bulge here. Okay, so remember that if you identify that in the lateral projection, remember that there are three structures that can be affected, and try to separate them out based on the other projection. So if we come back to this image, and if we believe that that's abnormal, I'm not sure I can pick something clearly abnormal, but at least I would say that the right atrium is not enlarged. So whatever is happening is probably affecting the aorta, which is that line. Let me double click here. It's going to be this line, and there, I don't know where we go. Probably continues there. And then this, which is a pulmonary outflow tract. Okay. So that is to clarify that. Okay. And then I would 100% agree with the comment about the left atrium. So remember that we don't want that bulge coming out here. It's not severe because if you wait enough, you're going to lose this kind of waist, this contour, we call it like waist. This is kind of the enlargement of the left atrium, which is not severe. If it gets more, then this line turns to be more straight, and we lose this border basically. So this starts going more straight and more caudal. So it gets like this, like in the classic case is going to be in a mitral insufficiency case. Okay, good. So that, I think we are in agreement. And then, yeah, so no problem. And the only thing that I wanted to mention, and I'm sure I'm a bit boring with this, is that when someone mentioned the cardiomegaly and everything, I maybe I shouldn't, but almost roll my eyes, because in my eyes it's very hard, even in a case, I would say that there is cardiomegaly in this case, but I would even argue that there is a mismatch in between the lateral projections where the heart looks big and then the DV projection where the heart doesn't look like extremely big. So for me, it's a very hard call and somehow not as useful as looking at the shape of the heart. The shape of the heart, I think, gives you a lot more clues and more specific information and a lot less controversial information rather than the size. The size, I find it always very controversial. So the only exception to this rule is that if you have this dog and then you diagnose the disease, whatever, and you start treating, and then you want to follow up, the cardiomegaly, then now you are dealing with one individual, and then you can compare it over time. And then all the rules about the cardiomegaly and all of that then applies very nicely and it's okay. Otherwise, I'm not saying that it's bad to look at the heart. I would say just look at the heart, at the size of the heart. I would suggest pay more attention about the shape of the heart. The shape of the heart is going to give you a lot more information. Anyway, so we are in agreement there. I'll probably, let's go to the lung changes, because that seems to be, we are all in agreement. Probably we are not in agreement in the pattern. I'm not sure if it's necessary to be in agreement with the pattern, as long as we are all in agreement that I think that lung is too wide. So even without trying to stay away from this debate about which pattern we are dealing with, I think we all agree that at least in this part of the lung, it's very hard to see the vessels, or the vessels are not very sharply delineated. Okay, so the same thing here. Probably here they become a bit more, so there's some component of superimposition and expiratory radiograph, but I think there is, and probably someone picked this area as being more affected compared to the other one. My only comment to this is, and before we make that call, which I think I agree with you, be aware that there is some degree of rotation, and then just a little bit of rotation can make superimposition of the soft tissues mimic or look like there is lung disease. So I don't think this is the case, but I think probably this is the case in the asymmetry in the cranial part of the thorax. I would say that this difference, if you see a difference, is the difference between superimposition of the scapula on one side more than the other. See that the volume of the lung seems different. I think that's not real. That's the little bit of rotation. But I think this is real. And how do I know? I don't know. I know an outplay, I don't know for sure. But be aware that a mild rotation can look like lung disease. But in this case, probably if we put all of the images together, I think it becomes clear that there is an increase in the opacity. I would add things like it's diffuse, and I would add things like against like a multifocal or a focal lung disease. That's clearly not the case. And then I think that's a very important thing, that is diffuse. And then in terms of the pattern, I think it's the classic. I know that there is a bronchial component, but I'm going to explain why I think there is a bronchial component. I think basically this is a beautiful example of reduced visualization or poor delineation of the vessels. And I think that's because there's a little bit of fluid surrounding those vessels. So I would call this an interstitial pattern. When there's a severe interstitial pattern, that fluid can accumulate around the bronchi and can look like a bronchial pattern. So then that's where we get into the debate, and almost like a silly debate, as long as we all agree that there is an increased lung opacity that is diffuse. Okay. Please disagree with me or bring questions if what I'm saying is complicating stuff rather than clarifying them. Let's go through the changes in the vessels. Are we all in agreement with them? Do you want to modify something, add something? So the call is that both the pulmonary arteries and the veins are enlarged.
Mariano, I missed the beginning, so I'm not sure what other people said, but to me, the ones crossing the diaphragm are quite asymmetrical in size. So the right side's massive and the left side is kind of, well, it's small, if anything.
Okay.
Yeah.
Okay. So maybe probably I would disagree there, and I would try to explain why. And probably I would say that it looks like this if you don't consider one little hint. So if you go, so first let's clarify that this is the artery and that's going to be the vein. And also let's clarify that a very useful way to deal with this objectively is to compare it with the 9th rib. So if this is 13, 12, 11, 10, 9, so you can compare, so where this artery, vein or artery crosses over or superimposes over the rib, that superimposition should create like a square, like a perfectly square image, okay? So meaning that the cross-section of the artery and the cross-section of the vein should be similar to the cross-section of the rib. If that is the case, then you have like this, instead of being rectangular, like in this case, it should be square. So in this case, then if you compare it against the 9th rib, then both of them are clearly, not only clearly, but objectively enlarged. Now, let's go through the comment about the asymmetry. I think here is very clear the rotation of the heart, and the lid is not alone, but it's enough So I think this, which is the pulmonary vein, the left pulmonary vein, is kind of going under the spine, but it's still enlarged. And if you compare with this side, it probably looks like less, but this is clearly enlarged anyway. This is the pulmonary artery. I think you can trace them less towards that area because of the rotation. And probably here they are more closer to the spine compared to this. Basically, you are doing everything by rotating the thorax. You are making these vessels more clear and these vessels less clear. But I wonder if there is a real asymmetry or is just the positioning. And again, that's why now this is kind of a defense of radiologists being picky about positioning. Like a little bit of rotation, it can just make a big difference. So I think I would probably pick that explanation rather than to start thinking about a disease that can result in an asymmetrical enlargement of the pulmonary or the veins. We can play with that idea for a minute. There is one disease that can result in like all the rest of the vessels looking normal and then a pulmonary artery and vein to one lung lobe looking enlarged. But I think the actual explanation is that the rotation not real. Hopefully you are happy with mine. Hopefully I convinced you. Okay.
Thanks.
Anything else? Oh, we are left with the changes in the abdomen and the poor serosal detail. Jen, do you want to change your mind? Do you want to reconsider your? I think your comment is extremely important because if we are dealing with heart disease, and then we add to that combo the fluid in the abdomen, and I will probably add hepatomegaly. Now we are dealing with a piece of extremely important information. So I think it's relatively important for us to try to decide if there is a hepatomegaly or not, and then if there is free fluid or not. So do you want to reconsider the idea of free fluid? Do you want to stay with it? Do you want to consider an alternative explanation?
You mean like, as in, do I think it's?
Do you still believe that there is fluid? Do you think there is another alternative to explain the poor detail? I agree with you that there is poor detail.
Well, I mean, you can see the gas in, I don't know, maybe the colon there, and you can see the border of the one of the liver lobes ventrally on the lateral projection. So yeah, maybe less likely fluid, more likely, I don't know, I guess hepatomegaly or some other increased soft tissue.
Okay, but remember that hepatomegaly should not result in reduced detail. So it should result in the border of the liver extending more caudally, round it probably will be a key element, or displacement of the gastric axis.
Yeah.
Those would be features, but not the erase, not the inability to see the contours. That there are other explanations for that. One of them is the one that you provided, which is fluid. But I'm wondering if you are aware of another possibility another explanation.
This is only basically a puppy, so that there won't be much fat in the abdomen, and to contrast the content. So I think you would have to rule out the lack of contrast due to age before you could put a pathology on it.
Okay, I 100% agree with that. So hopefully you listen to that, Jennifer. So it's a puppy. So puppy is usually, so I think there are two components there. There is one, the type of fat that they have that is less contrasty, and the other one is that they have less fat. And then this is like a relatively thin animal. So you have a lot of arguments to believe that to explain that poor detail, other than the explanation of the fluid. If we go by the liver, be careful, because in puppies also, we are missing the mineralization of the cartilages. So almost every liver looks like an enlarged liver because we kind of miss that rib cage. Remember that there should be cartilages coming like this. So it looks like the liver is all in the caudal abdomen and there is no liver in the renal abdomen. Actually, that's not true. What we are not seeing is a mineralization of the cartilage. So it gives you the impression that the liver is enlarged. If we go by the borders, they are not rounded. And if we go by the gastric axis, which I believe is the most important thing to look at, the gastric axis is okay. So confusing case, but I think at the end of the day, the abdomen is okay. And I think that's a very important piece of information.
I'm not convinced I can even see the gastric axis. Can you?
Oh, well, so this is the colon, and then this is gas, and then probably the stomach is somewhere. Probably that's the pylorus, and then this is the gas. Hard. But what I'm sure is that this is the heart. This is the stomach.
Yeah.
Based on the gas, and that is not. That is. We want the stomach to be within the rib cage, and then if we come here, the stomach is within the rib cage.
Yeah.
The colon is not being displaced. So again, I agree with you. It's not that clear. There's not that much detail, but you go by hints. Yeah.
Yeah. Okay. Thanks.
Well, good. So now I think we went through the findings, and now we need someone trying to bring all together. So what's happening?
The congenital defect I mentioned earlier is a patent ductus arteriosus.
Yeah. So how many of the findings can you explain via PDA?
I think the enlarged pulmonary vessels would probably fit that.
Mm-hmm. What about the enlargement of the left atrium? So something that we haven't mentioned yet is in that PDA situation that you are contemplating, are you contemplating a left to right or a right to left?
It's a good question.
Left to right.
I hadn't contemplated that.
I think because it's so young, you'd think it would be left to right, first of all.
Yeah. Yeah, I agree.
And then maybe it's getting some congestive heart failure secondary to the fluid overload of the lungs.
So then I insist, is that a failure on the left or on the right? I know that it's a left to right.
If there's
Left
pulmonary-
failure,
yeah,
left-sided failure.
if there's
Okay.
pulmonary congestion.
So then that is the hypothesis, and if that is the hypothesis, so I clarify the hypothesis. The hypothesis is the PDA, and then there is a left-right PDA, and it's starting to fail. And then the failure is going to be a left-sided failure. So if that is the hypothesis, I can bring them back and say, you know, how nicely that fits. So can we explain the cardiomegaly? And can we explain the enlargement of the left atrium with that scenario, with a PDA, left to right PDA? Can we explain cardiomegaly and left atrial enlargement? Yeah, no.
Yes.
Yes, absolutely. Can we explain enlargement of the both the pulmonary arteries and the veins?
Yeah.
Yeah, absolutely. Can we explain the increase in the lung opacity?
Yeah.
Absolutely. And then can we explain the weird looking aorta or that increase whatever in the cranial mediastinum? And I think
Yes.
that's it. So basically, there is a very nice fit. That doesn't mean that is the disease, because I think probably the other thing that we need to consider, and this in the context of a puppy with a murmur, okay? I'm probably discussing more about the murmur can, will help us be more certain about what is going on, or be certain about it. Radiographically, I would include something like a VSD, like a ventricular septal defect as well, because radiographically, it looked very, very similar. It's still a left to right shunt, volume overload in the lung. And then when they fail on the left side, those cases. So then radiographically, I would probably include that differential. And obviously, Yeah, you want to do an echo. Let me come back to this, or maybe not. So this is a PDA. This is a PDA that is starting to fail. And what I thought about doing is showing you a CT to show you actually the anatomy of the PDA. So this is a cross section. This is an ECG gated CT. So basically, it's a motionless image of the heart. And let me reconstruct, because there are one more feature that is not that clear in this case, but I wanted to stress because this at least makes a beautiful exam question. And then I hate to remember by heart. I want to understand things better. So I thought coming back to the anatomy is a good idea. So, okay, so CT, ECG gated, now we can see the chambers. Let's go slowly and try to identify them. Let me move this out of the way. Okay, good. So I would suggest we concentrate on this image, which is the sagittal, and then let's try to identify some structure. So first, to stress the idea of the clock face analogy, this is the left atrium, and you see that that beautiful border, that's what, when it gets big, this is what produces that bulging. So that makes sense, that the pulmonary vein should be entering here. This should be the mitral valve, and this is the left ventricle. Remember, when this gets big in the radiograph, we don't see any bulging because the wall is so thick. We just see that the heart gets tall. Then this is the aortic valve. This is the aorta, and then it goes the ascending aorta. This is a brachycephalic arch, and then it goes descending aorta. Make sense? There we go. And then if we go to the right, then we have the pulmonary outflow tract here. This one that is going to go to the right, kind of goes around the heart, and then it goes into the right ventricle. So this is the pulmonary outflow tract. This is the pulmonic valve. This is the right ventricle. Again, radiographically, if you go the clock face analogy, enlargement of the right ventricle results in increased sternal contact. Makes sense? Perfectly fine. The ventricle is just against the sternum. If this gets big, increased sternal contact. So clock face analogy really works well, and is, to understand the anatomy of the heart, a CT works well. So let me bring, so maybe I can come here and show you the actual PDA. So what we are after is a communication between the pulmonary artery and the aorta. So that's it. So this is the abnormal structure from here to here. And if I go carefully, so this is the pulmonary outflow tract, and you see that there is a communication with the aorta. So that's the aorta that comes like this, brachycephalic arch, or maybe left subclavian there, and this is brachycephalic arch, ascending aorta, descending aorta, and then we have this abnormal vessel that communicates the aorta with the pulmonary outflow tract. So that's it. It's there. And the reason why I wanted to show it to you in the CT is because I also want to show you how it looks and where that is in the dorsal projection. Makes sense? Now we are looking at the dog from either from ventral or from dorsal, more from dorsal. So I'm going to make this larger, and then let's go through anatomy again. So let's go from ventral to dorsal. So this is very ventral, close to the sternum. This is the left ventricle. This is the right ventricle. Let's go first with the left ventricle and see where it communicates with the aorta. Okay, so that's the aortic valve. That goes like this, ascending aorta. This is going to be the brachycephalic arch, left subclavian, somewhere there. And then it's turning into descending aorta. There, this one, this guy. Okay, so we know that part. And then let's go to the right. So the right is, that's the right ventricle. And then it's going to turn into the pulmonary outflow tract here. And then it's going to divide into the pulmonary arteries. Make sense? So one to the right, one to the left. And the abnormal, the PDA is exactly this structure. It's in between, it's communicating the aorta with the pulmonary outflow tract. And maybe if I bring this at the same time, you will see better. So I can bring it at that level. So what I'm gonna be scrolling here is gonna be this blue line, make sense? That's gonna go from aorta to pulmonary outflow tract through that abnormal structure. Okay, so if you see that line, I'm moving. Now the blue line, so aorta, I go ventrally, you follow that line, and then that's the PDA that is going to communicate the aorta with the pulmonary outflow tract here. And so the reason why, again, I wanted to bring this is to show you where in the clock phase analogy that PDA sits. And it's in that border. Makes sense? It's like just in the border of the aorta. And if this is large enough, it's going to produce a characteristic, and the books are all about that, like a focal dilation of the aorta. And then if you find in a radiograph, so you have the murmur, and then you have the enlargement of pulmonary arteries and veins, enlargement of the left atrium, you may have enlargement of the left auricle, and then that bulge in the border of the aorta, then it's kind of, then you have a diagnosis of a PDA. Make sense? So this is so let me bring, I thought about bringing you this. These are the radiographic changes of PDA. And hopefully now it makes sense, also giving you the CT so you can understand anatomically where are the things. So there's a dilation of the proximal aspect of the descending aorta. I would probably add more than dilation, is a focal dilation. And that's going to be the ductus. And that's exactly what I showed you a minute ago. And I will bring the radiographs to show you exactly what you need to look at. Then enlargement of the pulmonary arteries. And that is because there is a pressure overload and a volume overload. Enlargement of the left ventricle, and that's because there is a left to right shunt. So there is a volume overload on the lung, and then which is going to result on the left atrium and left ventricle. And then enlargement of the pulmonary arteries and veins, again, because of the volume overload. So this is kind of an exam question. Yeah, but I wanted to go through in detail and show you the anatomy so you don't need to remember by heart. So if you go back to the radiographs and you go back to this projection, what you should be looking at in a case like this, so it's a puppy, murmur, enlargement of pulmonary arteries and veins, the ductus should be, the bulge should be there. And I think there is a little bit of a bulge. You may say, well, I'm not going to trust on that. And I completely understand with that. But that's in theory where you should look at. That's the focal dilation. This border is the left, this is the pulmonary outflow tract, sorry, which both should be enlarged because there is the volume overload left to right. So the pulmonary outflow tract, in the same way that the pulmonary arteries are enlarged there, is enlarged here. So it's not hugely enlarged, but that bulge is up there and it's abnormal, it shouldn't be there. That together with the bulge, focal dilation of the aorta, then you have enough information. Or let's say like this, it fits with what the book is saying. That CT is from this same animal, and you can see that little bulge. So this is kind of a nice teaching case. Okay, and as usual, we went too far, we took too long, and then the next case, which we are going to leave for next week, I think is going to build on this one. Makes sense? So now we review kind of a normal, let's call it, it's not normal, but it's the left to right, classic, probably that's a way to define it, PDA. And then we're probably going to build on this to go through the next case, which is going to be next week. And I want to make one comment, and I'm not sure I'm an expert here, but from all my readings, or probably we can leave it for the next time, because otherwise I'm giving you too much information. I'm going to take note, and then I'm going to make sure that thinking process in the next one. Otherwise, I'm going to give you information. Anyway, do you have any questions?
That was an awesome example, Mariano. Thank you.
Well,
Yeah,
I
that
always
was
promise
very
that I will
good.
put, I'll try to remember and put this at least a video so you can, I think the best way to learn like the heart anatomy and then the clock phase analogy, which is so useful, is to go through the CT, to make the same plane and go back and forth, and you see, all the bulges there, where they are coming from. And then yeah, so I think that clarifies a lot.
Also helps putting almost sort of mirroring them up with the ultrasound images for me in particular, because I'm ultrasounding
yeah.
the heart a lot. It's
Yeah,
so nice
yeah.
to see that 3D kind of thing.
Yeah, yeah.
It's great.
And then
Yeah.
I can give you examples of CTs, like ECG-guided CTs. And what I found extremely interesting, if you're going to do echo, is that you can, let's say, let me show you. So as I was doing, you can go with the different planes. So you can even mimic the echo planes. Make sense? And you can learn so much. The relationship in between the structures. Make sense? So you can go, I'm going to go along the long axis of the heart, go ventral. So then this is kind of a short axis, and then you can go like that. So, you start from the beginning, like the section down here, right heart, left heart. And then from there, I think it makes so much sense. Then you get familiar, this is the apical view. You go more ventral, you're going to have the, right, left, and yeah. So spending time with a CT that you can play with the planes and learning that anatomy helps so much.
Can you just explain when you just make all those colored lines on that? That really confuses me.
Okay.
Because they're all moving differently, and can you just slowly explain when you're moving one, what's happening with the other one?
Okay, so let me do something that it may help. Okay. So when
Helena,
we take a so this is just to, I'm gonna come back. So what I'm trying to show you is that what we have is a volume of information. So in a radiograph, we have a layer of information. Makes sense? It's a 2D. So it's like one axis, another axis, and then the third axis is the other projection, okay? And that complicates things because we have the superimposition problem and all of that. When we acquire a CT, basically what we have is a volume. So there are three dimensions. And then, so we can go through that volume, and then we can go in different planes. So this is, I'm showing you the volume. Makes sense? So there are 3 dimensions. In one dimension, another dimension, and then there is a third dimension. If I bring the images, okay, that's okay. And then I'm gonna just make a plane. So there is a cube of information, and then the lines are basically showing you planes within that cube. And which are the planes? And there's a very easy way to deal with that. Okay, so let me bring this. Okay, we are gonna go like that. Okay, so I'm gonna adjust the planes based on the dog, not based on the heart. Okay, and I'm gonna bring it kind of a normal looking situation. Okay, so this plane, which should be familiar, it's like a lateral radiograph. That's the spine. Okay, that's the heart. The sternum should be down there, but it's just one plane. It's called the sagittal plane, and here is a yellow frame. So that yellow is telling you that is represented on the other images or planes by a yellow line. Okay, so this image is a dorsal image. So in here we go from dorsal to ventral and cranial to caudal. Okay, in this one, which is purple, is this line in this plane. So if I move the purple line, the purple image changes. Make sense? So I'm moving the purple line, the purple image changes. Or let's do it like this. I'm scrolling through this image, and then that's a dorsal plane where we go from cranial to caudal from right to left. And then if I go through that plane, then the purple line moves. Make sense?
Okay, yep.
And then in the third image, which now is going to be dorsal, ventral, and also right and left, this should be flipped, left and right, then this is going to be the blue frame, and it's going to be represented by the blue line.
Ah, okay.
Okay, so if I move,
Is this just on Horus, or is this?
well, actually, we have one in Asterisk, which looks the same. I can show it to you.
Okay,
And then
cool.
basically,
Thank you.
so these are the three, and now I make like very right angles. Make sense? So then it's easier for the anatomy to get familiar with anatomy. But then, you can scroll through. The other thing that you can do is you can move these. Make sense? So then the planes are not perfectly sagittal or dorsal or transverse, but they are. For example, if you want to look at the spine, so I will put that over the spine, and then I would just make that plane over the spine. So now in the other projection, in the purple, now I get the spine, including all the segments. If I rotate that, then I'm going to have one. Make sense? So basically, you have like a volume of information, and you can slide that volume as you wish. Even more, you can. This is probably getting too far, but I'm probably you're not that interested. But you can do like a curve, so you can even reconstruct that using like a curve. So you can go like that and say, well, I'm gonna reconstruct well, I picked the wrong thing. But I can just pick a line, which is gonna be a curved line, and then the machine is gonna reconstruct something. It's gonna make straight something that is not straight, like curve. So for example, you can use that for the teeth. So you can draw a line around the teeth, and then it's gonna turn that curved image into a plane. So you can look at all the teeth at the same time. So there are hundreds of things that you can do with this volume of information. The big concept is that this is 2D, makes sense? And there is no way you can go, is everything in one image, both sides? Like in here, this is 3D, and then you can slice that volume of information as you want. The other thing that you can do is to do volume rendering. So this is the volume of information. Make sense? And it's even going to look more familiar if you make it really square. Let me see. So this is it's not square because the machine acquired like a cylinder, but this is what the machine acquired. And then you can go inside. Makes sense? You can, and now because I'm changing the windowing, now you have a volume there, and you can even crop and then go slice it in. Makes sense? So once you have a volume, then you can play around with the volume of information in a very, it's the nature of the modality is different. And going through these, I think helps not only understand CT, but fully understand what a radiograph is. Makes sense? You are negotiating a plane, you are negotiating one dimension, you are losing that dimension, and then that brings a lot of complications in everyday reading. That obliquity that we've got in the radiograph is because we've lost one dimension. You don't have obliquity in a CT. Makes sense? Because you can slice it anyway. So it's good thinking about this. Next time I see you sitting there, I'll show you how to play with this. The more you play, the more you understand the dimensions and then the effect of obliquity in a radiograph, and also it helps you understand anatomy. I think that's probably the most valuable. Yeah.
Yeah, that's really helpful. Thank you.
All good. Okay, and with that, we are done for today.
Thank you.
That was
Thanks,
really
Mariano.
fantastic.
The case is already there for next week, and look at it carefully, and you try to use the knowledge, the clock face analogy, think situation, and the signament, and all of that, and then so the more you commit to your diagnosis, the best the discussion is going to be, even if you are wrong. Make sense? So look at the images, go and try to make sure that try to figure out what's going on, and then try to build a position. And then next time we discuss these positions and the arguments why you go one way or the other. And then from that, it's gonna be it's a very interesting case.
What number is that case, Mariano?
So it should be the last one. Let me just bring
Okay.
that.
Most
75.
recent. Okay.
So it's here, topics 75.
All right.
This one.
Great. Thank
This
you.
is a real case. This case came to the clinic the other day, and I was just walking by. And after years of doing this, you have like you don't need to think a lot. You kind of, your eyes brings an alarm. And I was just walking by, and I saw this case, and I said, I need to talk to the clinician because this is a very characteristic appearance. And then, then we'll learn more about the case. So it's a very interesting case.
Cool.
Mm.
Excellent.
Thank
Thank
you.
you.
Mariano.
Yeah, thank you. Excellent.
Bye,
Thanks,
everyone.
Mariano.
Thanks, Mariano.